Okay, so your formal lab report is due 2 weeks from today. So I actually changed the due date to midnight, 2 weeks, so it'll be midnight on a Monday. So this will be uploaded to the Canvas site, and Turnitin is going to analyze it for evidence that you plagiarized. So you want to make sure that you write everything in your own words. It also checks it against other student papers. So like if you found a student paper on plenary regeneration and tried to use that word for word, then we'll probably detect that as well. So when you look at this, I'll change that due date till the 12th. There is on your Canvas website in the very first section, there are some directions for how to write, including how many references you need. So you need to have at least 2 references in your report. So I'm hoping that you might have more than that. And I'm hoping that you might have not references like your textbook or like a dictionary, but actually have references from an article. Preferably like a journal article would be best. And so if you go to Google, if you haven't figured this out yet, you can type in Google Scholar. So if I go to Google, so I just type in Google Scholar here. So now Google is just going to give me scientific papers on the particular topic. So if I wanted to do, say, diving reflex, which we're going to do in lab this week. So you could do the diving reflex. You could look at this particular paper right here. This is actually an older paper, but they actually have this paper, and you could use this as part of your references. Okay, so Google Scholar is a good source for finding reflexes, or not reflexes, for finding sources, excuse me, references, for your topic. Okay. So you'll notice that you could do your scientific paper on heat loss, so that would be the thermoregulation. You could do it on planaria orientation, so that was the behavior. You need to use the entire class's data if you do it on that particular topic. Planaria and regeneration of eye spots, that would just be your group's data, or the diving and heart rate, which is what we're going to be doing this week in lab. So you should have time to write that up, because you would have over a week to do that. So even though you've carried these out in a group, you could state like, we did this, right? Remember that your methods section should not be a written list of procedures, but rather it should be, we did this. It should be in the past tense. So just some statements about what you did and how you performed the experiment in the past tense. So also there is, if you go back to your paper, this is a rubric that we're actually using, and you might have seen it before because we're trying to use the same rubric across different courses and across different instructors. So all the science instructors are trying to use the same rubric for grading. And so as you do this, you can notice that this is how I'm going to grade. So if you have a title, right, and it identifies the topic and what's being assessed, you get 3 points. If it's absent, you don't get any points, okay? So what I would do is as I'm writing my paper, I might look at this rubric just to make sure that I am putting everything in that is required to get the full points, right? So it just came out to be out of 48 points rather than 50 points. Okay, are there any questions about the lab write-up, formal lab report? How many people have actually done a formal lab report before? Written one up? Okay, so some of you haven't. So if you have questions, make sure you ask me, okay? And so this is something that you could easily, if you incorporate everything, you could easily get a really good grade on this, which will help your grade overall. Okay. So we didn't have lab last week. So I sent out an assignment. And how many people actually completed that assignment already? Okay. So you want to make sure that you do that before the end of the quarter. So you just need to go through the quiz, the multiple choice questions, and write the correct answers to those. And hopefully that was a good review for the respiratory system. And then it is actually looking at prepared slides of heart or not, of lung tissue, and looking at how smoking affects the development of the lung. Okay. Yes, question?
When is the lab due again?
It is due the very last lab. So that is in, we have 2 more labs, so it's like in 3 weeks. Yes, probably. So it's on your syllabus as just being when the lab, I think it's on there. Yeah. So it's when the lab practical is when you turn in your lab notebook. So it's the same time as the lab practical.
Oh, okay, so it's the 14th.
Is that the 14th? I'm not sure. It is the 15th? Okay.
Yeah, it says 14th.
Okay, so it should be the 15th. Okay. So today we're going to finish up talking about the circulatory system, and we were talking about the evolution of the 4-chambered heart. So what was the advantage of having a double circuit circulatory system over a single circuit circulatory system? So it eliminates the mixing that actually amphibians have a double circuit, but they actually have a 3-chambered heart. So what would be the advantage of, say, if we just look at the fish and the amphibians? What is the advantage of having a single circuit versus a double circuit circulation? So this one goes out to the gills and then out to the body and then back to the heart. This one goes out to the lungs, back to the heart, out to the body, and then back to the heart. What's the advantage of that? Higher blood pressure, right? So you can see here that with the fish's single circuit, it's going to go out to the lungs where it's going to go through very small vessels. And when it goes through these very small vessels, it encounters a lot of resistance to flow. So we say the peripheral resistance gets high, and that's going to slow down the blood. And then the blood has to go out to the body where it has to go through some more capillaries, and it's going to slow down even more. And then eventually has to get back up and back to the heart, where the heart, when it pumps it out, boosts the blood pressure. So you can say the double circuit circulation, the advantage is that it keeps the blood pressure high. So it boosts the blood pressure before the blood goes out to the capillaries in the body. Okay. So the advantage, however, of a 4-chambered heart is what, like Dora said, the 4-chambered heart keeps the oxygenated and unoxygenated blood separate from one another. So when we see purple, that means that there is mixing of oxygenated and unoxygenated blood. Here in the 4-chambered heart, which we see in birds and mammals, there is complete separation. And just as a side note, it's kind of interesting, when we look at the blood and when we look at it through our skin, the blood in the veins actually looks blue, but it isn't in reality. It is actually not blue. Oxygenated blood is bright red, and then so it's dark red and bright, and then the blood from the veins is also red. It's just a different shade of red. So it only looks blue because of the way that light is being reflected from the skin. So that's why it is drawn, however, as blue, but it's actually not blue when it's entering the heart. Okay, so here's a picture in your book that shows this double circuit circulation and the 4-chambered heart. And we are going to talk about the structures of the heart. And so I'm going to give you a handout. So you should become familiar with these images. So on the first side, you have the heart open up. And then on the back side, that is the heart closed. blue everywhere. Just in my bathroom. The 16-year-old was supposed to just do some straights. She's like, Mom, let's just do your whole head. I'm like, sure, what the heck. Okay. So let's look at the other image, the one that's on the front side of that page. Okay. So remember that we have a 4-chambered heart. The thing about the heart that is a little bit tricky is that you have to remember that the diagrams are from the perspective of the person. And a person in anatomical position is kind of like standing here in front of you. So when I look at these chambers, if I look at what is on the left side, that is actually the right side of the heart. And then if I look at what is on the right side, that is actually my left side of my heart. So this is where students get confused. Okay, so I want you to label this one as the right, and I'm just going to write it like RT. This is my right atria. Notice that it is on the left side of your paper. Okay, this would be my right ventricle. Left atria. This is my left ventricle. Okay. So the atria receive the blood. So the right atria is actually receiving blood from the body. And so this major vessel here is what we call the superior vena cava. So a vena cava is a vein because it is returning blood back to the heart. So then the one that is coming back from the bottom of the body, that would be my inferior vena cava. So you'll notice here that there are valves in the heart, and what those valves do is they prevent backflow, so that blood is going to flow through the heart in one direction. So this valve right here is called the tricuspid valve. And it is going to prevent backflow from blood that is in the right ventricle back into the right atria. We don't want blood to flow in the wrong direction through the heart. This blood, or this valve right here, is called the bicuspid valve. It also has another name, which is called the mitral valve. The mitral valve is the valve that oftentimes wears out. So what it does, you get blood that doesn't flow properly through the heart, and when that ventricle, the left ventricle, contracts to send blood out to the body, it sometimes goes back up into the atria, and so that prevents the blood from flowing properly. So that's the valve that a lot of people have to have replaced. And so they can use pig valves. The heart of a pig has valves that are about the same type, and they also have synthetic valves that they can use to replace a worn out valve. Okay, so let's start here with the right ventricle. So the right ventricle is going to need to pump the blood up and out of the heart. And you'll notice that this right here is the beginning of what we call the pulmonary trunk. Trunk. And it is going to branch into what we call pulmonary arteries. So this is a pulmonary artery. Now, what do you notice that is strange about that pulmonary artery on this diagram, not necessarily on yours because it's black and white? What do you notice that's strange about that pulmonary artery? It is blue, right? So this is the only artery you have in your body that is going to carry unoxygenated blood. Most arteries carry oxygen-rich blood. So by definition, an artery is something that is carrying blood out and away from the heart. And so pulmonary means that it's going to carry it to the lungs. We notice that there is a valve right here, and this is called the pulmonary semilunar valve. And the reason why it's called the pulmonary semilunar valve is that semilunar means half moon. And the shape of it is actually what is going to keep the valve closed after the blood has been pumped up and out. So we'll talk about that in a second. Okay. So what do you think these are that are coming into the left atria? If they're not pulmonary arteries, what do you think they are? They're not arteries, they would be veins. So these are the pulmonary veins. Weirdly, they are red, but they are just returning back from the pulmonary circuit, back from the lungs. So they're going to be carrying oxygen-rich blood. So then the blood goes into the left ventricle. And this is, it's kind of difficult to see, but this is another pulmonary or semilunar valve, not pulmonary, semilunar valve. And this is called the aortic semilunar valve. Okay. So that is going to connect with this structure, which right here, which is called the aortic arch. Okay. So that is the major blood vessel whereby all the blood that is being transferred out to the body goes through the aortic arch. And then notice you have branches. So you have branches that go to the right arm and then up to the head on the right side. And then you have branches that go out to the left arm and then up to the head. Notice that it is kind of weird that it is asymmetrical. You don't need to know the names of those vessels, but one of them is called the brachiocephalic trunk. And then the other one is called the subclavian and the carotid. But notice it's kind of weird that it's asymmetrical. So there's a difference between the right and the left sides of the circulation. And then if we look down here, what do you think this is? What major blood vessel goes down through the body, transferring blood to all the organs in your body? This would be the aorta. And it's actually the descending aorta. So this is what is going to take the blood out to your kidneys, out to your digestive tract, out to your liver, down to your legs. So that's the aorta, the descending aorta. So if you look at this heart, it is also asymmetric in that one of the ventricles has a thicker layer of muscle. So we'll say that this is thicker layer. Why do you think there is a thicker layer of muscle on the left side versus the right side? Right. So it is having to pump it against greater pressure. Your circulatory system is always filled with fluid, right? And so when it pumps, it has to pump it against all of the resistance of the fluid that is already out in the vessels. And so if it's going to pump it all the way down to the toes and all the way out to your fingertips, it has to be pretty strong. So it is thicker because it has to pump it all the way out to the body, whereas the right side only has to pump it out to the lungs. Okay, so it doesn't have to pump as vigorously. So the thing about these valves that are interesting is that the valves are what we call mechanical valves. So they're not like electrical valves. So electrical valves would be like I send an electrical signal out and the valve opens or closes. So a mechanical valve means that it is actually the pressure of the blood. So pressure of blood opens and closes. the valves. So when the atria contract, it forces, if this contracts right here, it's going to force that valve open. And then it's going to relax. And when the ventricles contract, they actually force, because notice how they're connected via this connective tissue to the heart muscle wall, it's actually going to force the tricuspid valve to close. And when it contracts, the blood flow forces that pulmonary semilunar to open, but the blood coming back is actually going to collect in those little pouches of the semilunar valves, and that is actually what closes them. So really it is the pressure differences as the blood flows through the heart that actually causes the opening and closing of the valves. That's kind of a cool mechanism. Okay, so this is not in your diagram, but we're going to talk about the cardiac cycle. And the cardiac cycle is the periods of contraction and relaxation. Cycles. Contraction. Okay. So you know these words as they relate to arterial blood pressure. So systole actually means contraction. So when we're looking at systolic blood pressure, this could actually be due to the ventricles contracting. So systolic blood pressure is when the ventricles contract. Okay. Systole is how you say that. Okay. Diastole refers to relaxation. And in terms of blood pressure, diastolic pressure is when the ventricles relax. So when we measure blood pressure in an artery, we measure it in terms of millimeters of mercury, which is exactly the same way we measure other types of pressure, including atmospheric pressure. So for example, you could have a blood pressure of this, 130 over 80. So that's pretty normal. Kind of the cutoff between hypertension and normal blood pressure is 140 over 90. But the 130 millimeters of mercury, that is when the ventricles are contracting and the blood is being forced out of the heart and into the arteries. And then when the ventricles relax during this cycle, the blood pressure actually goes down. And this is the pulse, right? So you feel this as a pulse. So you can feel the blood being pumped through the blood vessels. High pressure, low pressure. High pressure causes the blood vessel to expand. Low pressure causes it to deflate a little bit. So we feel it as the pulse. Now I just wanted to point out that the atria also undergo systole and diastole. So this is the atria relaxing and the ventricles contracting. So it's really important to realize that you have to have those coordinated. We don't want the atria and the ventricles contracting together. We want them contracting alternately so that blood flows smoothly through the heart. Okay. Okay. Now sometimes the heart does not work properly, and it can be due to the fact that the heart has been damaged. And the heart can be damaged by having minor heart attacks repeatedly where part of the cardiac muscle dies. And so the heart is not able to pump efficiently. And so we have what is called a left ventricle assist pump. And this is just a diagram showing how they would put a heart pump into a person. The pump actually connects to the bottom of the left ventricle, hence the left ventricle assist. And then notice that it bypasses the heart entirely, and it goes right up to the aorta. So somebody who has congestive heart failure and their heart is not able to keep up with the amount of blood flow they need might get put on a heart pump. This is not generally a long-term procedure. I mean, it's a long-term procedure, but it's not, generally doesn't work for a long period of time. So most people that are on heart pumps also are on a waiting list to get a heart transplant, where they'll take their defective heart out and then they'll give a person a heart from somebody who had died while their organs were still viable. Okay. So this part, actually, you do not see that at all. So that is actually underneath their diaphragm in their abdominal cavity, and then they have to carry around a battery pack with them. So you might see people that have this.
What happens when power goes out?
Then you die, right? Yeah. So you have to be careful about your control system. Yeah. Okay. You're dead. Okay. So we're going to talk about the regulation of the heart rate. I didn't even actually, I need to go back to that. Sorry, I just need to go back to that one diagram since we didn't talk about that yet. Okay. This is the atria, right? This is my left atria. This is my right atria. This is the way they look on the outside, and they are said to be the auricles because they look like ears, like maybe dog ears, right? Okay, so those are auricles, but they're part of the atria. And then we can see here that this would be the right ventricle, and this is my left ventricle. The red, which is the one that's on top, since you don't have the red and the blue, this is what is called a coronary artery. So what this does is this actually carries blood to the heart muscle itself. The heart muscle is highly dependent upon oxygen. So in order for it to contract, it has to have oxygen to produce ATP. So the artery is carrying oxygenated blood to the heart muscle. So sometimes those blood vessels get blocked, right? And so then if you have a buildup of plaque and you have a blocked blood vessel, sometimes what they have to do is that they have to go in and do bypass surgery. So a bypass surgery is just creating a new vessel around the one that is blocked so that oxygen can be delivered to the heart muscle itself. Okay. So sometimes there's multiple blockages, right? So it's like, I had to have a triple bypass surgery. Well, you had, 3 different blockages in those vessels. And we'll talk more about atherosclerosis later. But yeah, blockages, and what that causes is a heart attack, right? So heart attack. Okay. The veins are the blue ones, and I wish they were called coronary veins, but they're not. They're called cardiac veins. I can never remember that, but cardiac veins. And so they're obviously not as significant as the arteries because they're just carrying blood back to the right atrium, where then it's going to go out to the lungs and pick up oxygen again. So the heart has its own set of blood vessels that supplies nutrients and oxygen to the heart muscle so it can do the work it needs to do. Okay, so let's talk about regulation of heart rate, and then we'll watch a little video. Problem with OpenStax is it doesn't have very good images. nice colored pens. When I was in school, we had an instructor, or I had many instructors that used colored chalk. So everybody had their own set of colored pencils. And then our notes were very colorful. And we had to draw all of our diagrams. No handouts. Draw all the diagrams by hand. Okay. So the heart has what is called the intrinsic conduction system. So intrinsic means inside. Conduction means it's conducting an electrical signal, and it involves more than one part, more than one component. And so the first part of the intrinsic conduction system is what is called the sinoatrial node. And we call this the SA node. It is also called the pacemaker of the heart. The pacemaker on its own will beat about, or will send a signal about 75 times per minute. So 75 beats per minute is what the sinoatrial node will cause. We can modify that, and we'll talk about that extrinsically. So the nervous system actually innervates the SA node and can slow it down or speed it up. Okay. We also have what is called the atrioventricular node. And that's called the AV node. This functions to delay the conduction between the atria and the ventricle. So it delays conduction of signal. This allows the atria to relax before the ventricles contract. So the atria must relax before the ventricles contract. If your SA node is not working, the AV node can be kind of the pacemaker, but it only causes about 50 times per minute, so 50 beats per minute. It will send a signal. I think they're mimicking a prison kind of riot next door. Okay, so we also have the atrioventricular bundle. So this is a set of cells between the atria and the ventricles. And this is also known as the bundle of His. And so this sends the signal to the bottom of the ventricles, because we want the ventricles to contract from the bottom up rather than from the top down. If they contracted from the top down, all the blood would be forcefully pushed to the bottom of the heart, and that could cause damage to the heart wall. And then you would have also turbulence in the blood, but we want the blood to flow very smoothly in a laminar fashion, okay? So this sends signal to the bottom of the ventricles. And then we have the Purkinje fibers. So the fibers are named after a person, and these cause the contraction of the ventricles. So Purkinje, that's a J, Purkinje fibers. Okay, so in your diagram that I just gave you, what do you think this is right here? This is the pacemaker. So that would be the SA node. This one right here is the AV node. Then we have, I'm just going to label this, the atrioventricular bundle. It branches. We're just going to call the whole thing a bundle. So you have the right and the left branches. And then these are the Purkinje fibers. So they cause the actual contraction of the heart. So the whole thing, the whole reason we have this system coming down is to keep the ventricles, not letting them contract until the signal gets to the bottom, so that they contract from the top out, up, excuse me, from the bottom up, to get the blood to flow fluidly out of the heart. So we can actually see the movement of electricity through the heart using what is called an electrocardiogram. So this is sometimes abbreviated as ECG, or it can also be an EKG. So hear people talk about EKG. K, because cardio in German is spelled with a K. But the ECG and EKG are exactly the same thing. Okay? So this just looks at the flow of electricity through the heart. And so it looks something like this. So we have a little blip, and then we have a big spike, and then we have another little blip. Okay. So you see this running across the screen on the ECG when people are hooked up, right? They have those pads on their heart, and they're measuring their electrocardiogram. So this is what is called the P wave. And once you know the P wave, you just then use the alphabets. So P, Q, this is Q, R, S, and this is the T wave. This is called the QRS complex. So what that P wave signals is the atria contracting. The QRS is the ventricles contracting. And then the T is the ventricles relaxing. Okay. So oftentimes what they're looking for is any abnormalities. And one thing they're measuring is the distance between like the P wave and the S, or the P and the T, or the QRS and the T, or the Q and the T, right? So they're looking to see if there's any abnormalities in the way that electricity is conducted in the heart when they're looking at the electrocardiogram. Now, if it doesn't work properly, you can get what are called arrhythmias. So that means the rhythm of the heart is abnormal. A in front of anything means a bad rhythm. So arrhythmia. So one of the most common is called atrial fibrillation. And millions of people have this actually in the world. And sometimes this is abbreviated as AFib. And it generally happens when you're older. And in fact, a lot of old people just kind of live with AFib, and they call it heart palpitations. You know, so your grandma's like, oh, I'm having heart palpitations, right? Right. The heart rate races, gets really high, and then it starts to flutter. And so I believe that on your handout, I showed an example of the atrial fibrillation. It's kind of hard to see, but this is the normal ECG, and this is one of atrial fibrillation. So what it looks like is that you have all these little P waves that are kind of crazy, and then, oh, ventricles kick in, right? T wave, and then a bunch of, oh, right? So this is fibrillation of the atria. It looks like that, okay? This is not as dangerous, obviously, as ventricular fibrillation. So ventricular fibrillation is where the heart just kind of goes crazy and contracts asynchronously. So it just kind of goes like this, you know, it's like all over the place. So a heart that is doing that is not going to be able to pump blood. And so your heart could stop, right? Because it's not going to get oxygen, because it's not going to get enough oxygen, because the blood is not being pumped out properly. So what do they do if you get ventricular fibrillation? What do they do to you? They shock you, right? So you get what is called a defibrillator. Oops. Defibrillator, right? So that's a shock. And that can restart hearts that have completely stopped, or it can just stop ventricular fibrillation. So it defibrillates, stops the heart, and then hopefully the SA node will take over and you'll get normal beating of the heart. Okay. So one of the interesting things is that in some cases, the heart cells can actually beat outside of the heart. So you can take heart cells, nodal tissue cells, and put them in a petri dish, and they will continue to beat. And there are some organisms that actually have really resilient hearts that will beat even if they have been taken out of the body. And so when I was in graduate school, unfortunately, I had to do this experiment, which nobody liked doing this experiment, because we had to take 30-year-old turtles and we had to cut them open using a drill. Oh, you know how those things that do the circles? You cut them open, and then you pulled their heart out, and you could douse the heart with almost any kind of chemical to see how the heart would respond to it. And so here's just a short video of this guy that he's not actually doing it as research. He's actually eating the turtle, which would be better than actually just throwing the turtle away afterwards. So here's a guy.
Oh, this isn't the craziest thing I've ever seen in my entire life. Apparently, a turtle's heart still beats after you cut it out of its body. I was cleaning a turtle. I cut its head off like a half hour ago. But I got down to his heart, and I saw it was still beating inside there. So I cut it out, and that was about 3 or 4 minutes ago. And this dang thing is still beating. And that's proof that turtles are very crazy.
Crazy, yeah. Okay. So after we did the experiment, we would actually have to chop the heart into tiny little pieces before putting them into the garbage can, because we didn't want the janitors to come in and have like a freak out moment with the hearts beating in the garbage. Right? Yeah, really bad. Well, you know, it would be like half an hour, and they would be just like, still beating. We can't go home. It was a night lab. I taught in the night, you know, so we just wanted to go home after the experiment. Hearts were still beating. Yeah.
So they're beating until they run out of energy.
Mm-hmm. Yeah. So that all has to do with that intrinsic conduction system, right? It doesn't have to be a signal from the nervous system to beat like that. Yeah.
I worked for a medical doctor. They would do an EKG when I was testing, and like a couple times they see something on the EKG and they said, "Yeah, you're straight to the hospital." What were they worried about?
They were probably seeing some arrhythmias. So the EKG did not look normal. And so when you have this, they're worried about you having a heart attack. Yeah. So that if it is not fluid enough, and actually the more of a risk with AFib is that the blood starts to move pretty turbulently inside the heart, and you can get a clot. And so what they do when you have AFib is sometimes they'll put you in the hospital to monitor you. And then they'll try to get your heart rate down. So, because oftentimes it's elevated. And then they'll put you on blood thinners. And that is to prevent clotting. Because if your blood's like this, moving around the heart is going to clot. And then that's going to go to your lung, or you're going to have a stroke if it goes to the brain. Yeah, that's why. Okay, so on your handout, this is just a diagram that shows what the different parts. So the P wave, right, the beginning of the contraction, right, and then the relaxation. The atrial relaxation would be on here, but it is masked by when the ventricles contract. So that's why you don't have any atrial, anything that would demark atrial relaxation is because the QRS is on there. Okay, so we're going to watch a video, and one of the things that they mention is a procedure called ablation. So ablation is where they burn extra nodal tissue that has developed in the heart. So sometimes, and this sometimes happens in people that are very athletic, like long distance runners or long distance bicyclists, sometimes their heart gets large because of the amount of blood that they're pumping, and then extra nodal tissue develops, which is not coordinated by the SA node, and so then you get arrhythmias developing. And so ablation is just that process of burning that extra nodal tissue that has developed, that is not supposed to be there. And then there's also, in this video, they talk about the long QT syndrome. And long QT means that the distance between Q, which is the beginning of that spike, and T is too large. And this can actually be genetic. So it can run in families. Okay. And it can lead to massive heart attacks and death. So can lead to massive heart attacks. Even in young people. So you could be a person that is a young person like in your 20s and have never had anything wrong with your heart. But if you have long QT, sometimes the heart will just go into ventricular fibrillation, and then you'll fall down and you'll die, right? So young people dying of these massive heart attacks could be due to long QT syndrome. Okay, so let's watch this video. This video is about 20 minutes, and then we'll take a break, and then we'll talk some more.
Millions of people all over the world live with heart rhythm disorders. Many have been successfully diagnosed and treated. But for some, the problems are more complicated. Abnormal rhythms, arrhythmias, are often sporadic and mysterious.
The heart is a biologic organ. It's not a Swiss watch. And it can have little hiccups where the heart rhythm is not 60, 70 beats a minute on time all the time. It can have an extra beat or it can drop a beat, and often these things are of no consequence whatsoever. However, when they occur frequently and cause a series of rapid heartbeats, then the rhythm can get very out of kilter.
Susan Arvin's heart will sometimes race at more than 150 beats per minute for hours at a time.
blankets. Yeah, we could go ahead and bring the TV in.
The episodes are becoming a constant worry at home and on the job.
We're gonna actually do this right here. I have a circuit in my heart that causes it to beat in addition to the normal beat. I'm an electrical engineer with one too many wires, is what I tell the people at work. It does affect my life, and I'm ready to have it taken care of, I hope.
Doctors will now try to reorganize Susan's heartbeat and restore its natural rhythm. The normal heartbeat is a lightning-fast game of follow the leader. The leader is a tiny bundle of fibers located in the upper wall of the heart called the sinus node.
Most cells in the heart wait for a message that comes from the sinus node that says fire. And when that message comes to them, they then fire. Picture a row of dominoes that just go click, 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 all the way down.
That wavefront of electricity will trigger the muscle in the heart to squeeze. So when electricity travels from the top of the heart to the middle of the heart, the top chambers squeeze. When electricity travels from the middle of the heart to the bottom of the heart, the bottom chambers squeeze.
But in Susan's heart, a group of cells is disrupting the routine by beating too fast. The renegade heart cells aren't following the leader. They fire rapidly, out of sync, overthrowing the natural order.
These renegade heart muscle cells decide to take off on their own and control the rest of the heart. And they just take charge and start firing very rapidly.
In Susan's case, these renegade cells are quivering, fibrillating, in one of the heart's upper chambers, the left atrium.
Atrial fibrillation is the most common cause of a sustained rapid heartbeat. Probably 2.5 million Americans have atrial fibrillation.
Susan takes medication, beta blockers, to reduce the flow of hormones that increase her heart rate. But new treatment options are emerging. Dr. John Miller will lead a hunt for the cells causing Susan's rapid heartbeats, using catheters threaded through Susan's vein into her heart. Once they are in place, Miller manipulates one of the catheters by remote control from the next room. Probing the heart's chambers in search of disruptive cells.
We can find that area causing that rapid heartbeat. And we can localize the exact group of cells causing it. And then we can kill those cells.
Using high-frequency radio waves, the catheter knocks out the renegade cells by burning them.
It sounds, oh my God, you're burning my heart. In actual fact, the group of cells we burn is so small, the heart shrugs it off and it's really no problem. And the overall squeeze the function of the heart.
The procedure is called ablation. And every year, tens of thousands of Americans, like Susan Arvin, have hyperactive cells in their hearts hunted down and eliminated.
We got this map that localized it to a very small area here. This is probably just inside the vein a little bit. That's the hot spot. That's where it's emanating from. So what we're going to try to do is end up with a ring of these red dots practically surrounding this vein here.
Each red dot marks a burn the size of a pencil eraser. Heart cells destroyed to ensure they will no longer conduct electricity. in some patients, eliminating the problem forever.
The nature of what we can do in electrophysiology is a little different than other areas of cardiology. Coronary disease, for instance, you're never quite done with it. With heart failure, you're never quite done with the disorder. With many of the rhythm disturbances with which we deal, you're done. You can be completely cured of this.
The application of ablation was absolutely revolutionary. When we do an ablation, you now leave the laboratory a healthy individual.
Wonderful. Nothing but normal.
It's not with all the rapid heartbeats, but with some of them, it is absolutely that dramatic, and it is revolutionary.
I feel great. I really do. Before, I would work out vigorously. My heart would beat irregularly for 4 or 5 hours afterwards. You know, after the procedure, it took me a couple of weeks to get totally over it and have it out of my mind, but it's kind of like a weight's been lifted from my shoulders. You know, I didn't realize how much I was thinking about it and how it was weighing on my mind until I didn't have to anymore.
Burning renegade cells may have repaired Susan Arvin's heart, but rhythm disorders are too diverse for any single solution. There is no cure for Kevin Oyle's heart defect. Every heartbeat could lead to another arrest. Those who have been struck down by long QT are likely to be hit again. But there is help. Once, Kevin's friend saved his life with a defibrillator. Now, he takes one with him wherever he goes.
Your heart's great.
But this defibrillator is the size of a cell phone.
Sit up for me.
It is implanted in his chest, just below the left collarbone. Should his heart's rhythm fall into chaos again, the device is designed to fire automatically and shock him back to life.
The implantable defibrillator, implantable cardioverted defibrillator, ICD, is an incredible device that treats the fast heartbeats, stops them, and reverts the patient back to a normal rhythm. Patients now have an umbilical cord attached to medical therapy that they know will prevent them from having sudden death.
Have you had any problems at all, Kevin? No chest pain, shortness of breath?
It's like having an emergency room implanted in your chest.
Okay. No one's hit you there?
No.
A few decades ago, doctors could hardly imagine a device like Kevin's. The heart, they feared, was too delicate to tamper with.
You realize that cardiology is a relatively young specialty. The first really good textbooks on cardiology were written in the early 30s.
It wasn't until World War II that doctors, pulling shrapnel from wounded soldiers' hearts, began to learn how durable an organ it can be. After the war, cardiologists continued breaking new ground. To speed up fatally slow heartbeats, they used crude generators that sent a series of electrical impulses to the heart. They called the new machines pacemakers.
The original pacemakers consisted of a box that produced an electrical shock. An electrical shock was delivered to the heart through pads that were placed on the chest wall. This stimulated the heart all right, but it also stimulated all the muscles between the pads that you put on the heart and the heart. The chest wall would go like that with each heartbeat. Can't tolerate that very long, so it wasn't a good way to treat people.
A small group of heart surgeons and electrical engineers, some of them working out of their garages, experimented with ways to pace the heart using a less powerful series of shocks. The key was delivering the electrical impulses directly to the heart. For years, surgeons sewed the pacemaker's wires to the heart's outer wall.
When I first started doing transthoracic pacing, opening the chest, the heart was moving. You didn't want to make a mistake and hit one of the arteries in the heart with the needle, so you'd like to have the heart still. There were two ways to hold it still. One is to just hold it still, just not let it wiggle too much, and you can hold it pretty still with your hand. The other is if you have a temporary pacemaker in, and the patient needed a pacemaker, to turn off the pacemaker. I would say to the anesthesiologist, turn the heart off. And he would turn off the external pacemaker, the heart would stop. I knew I had 20 seconds before the patient got in trouble. And when it was stopped, I could put the needle exactly where I wanted. And I'd say, okay, turn the heart on. And he'd start the heart again.
These early pacemakers extended lives, but each patient had to endure major surgery. There had to be a better way. And Seymour Furman, a 26-year-old resident at Montefiore Hospital in the Bronx, found one. Instead of opening up the chest to get to the heart, Furman tried a different approach. Part of the body's own highway system, the veins.
The vein route is a natural one because that's the way the blood flows. You put the wire into the bloodstream and the wire goes down into the heart. And then it gets attached to the inside of the heart. And if you go through a vein, it's a small incision. It's a relatively superficial incision, so you're not spreading muscles and spreading ribs. You didn't have to make an incision in the chest wall, which was a big deal.
Furman's simpler and safer method opened a new era in cardiac treatment. With better batteries, pacemakers became smaller. Small enough to insert under the patient's skin. With microchips, the devices evolved even further. Some pacemakers keep the heart beating smoothly. Others help the heart muscle to squeeze more forcefully. And implantable defibrillators shock the heart back into rhythm when it beats out of control. Modern devices, like Kevin Oyle's defibrillator, also keep a record of each irregular heart rhythm on a tiny chip.
January 12th, February 23rd.
The machine has picked up possible arrhythmia. Have you felt anything? Oh, okay. We're going to see what's in here.
Okay.
Kevin's doctors can analyze his abnormal heartbeats months later.
The one on January 12th was for 1 minute.
Are you working out at all? Yeah. These are probably from your exercise.
Okay.
And they just represent normal beats.
With long QT syndrome, the condition haunting the Oyle family, this information is particularly vital. Long QT takes its name from the waves on the electrocardiogram. Each wave is given a letter marking a specific electrical activity. P indicates the sinus node starting the heartbeat. QRS is the electrical wave powering the squeeze of the lower chambers. T maps the electrical recovery or recharge of the heart as it prepares to beat again. In long QT patients, the time between the Q and the T, between the heart's electrical discharge and recharge, takes longer than it should.
Everything is in the timing. If the recovery hasn't taken place, you're now having the next beat falling on an incompletely recovered electrical activity. And that's what gives rise to extra heartbeats and then dangerous heartbeats.
Okay, we'll stop there. Okay, so let's take 5 minutes. Finish up the circulatory system. Thank you.
Yeah. So it was for the council.
Oh, did you see that I put the homework over there for you? Good job. Okay. So we've already mentioned blood vessels. We've talked about the arteries. Arteries, by definition, carry blood away from the heart. And in terms of blood pressure is always higher in the arteries. Okay, so we have a higher blood pressure. And in the major arteries, we actually have a pulse. So you kind of know when you have severed an artery versus a vein, because an artery is going to go squirt, 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 right? So vein, the blood is just going to flow out in a fluid way, but it is going to squirt because you have the differences in pressure due to the ventricles contracting and relaxing. So you have a higher blood pressure. You also have a high or a thicker layer of smooth muscle. So the smooth muscle is capable of shunting blood toward or away from a particular part of the body. So this is due to vasoconstriction, where we get a decrease in the diameter of the blood vessel, and vasodilation, where we get an increase in the diameter. So when a blood vessel dilates, blood will tend to flow in the path of least resistance. So constriction tends to shunt blood away. Right? And vasodilation shunts blood towards. So for example, if you're hot and you're sweaty, the blood vessels that are serving the skin will dilate and blood will flow to the surface of the skin and you'll turn red. And the reason for that is that you can then cool evaporatively by cooling down the blood that is going to the surface of the skin. And then when the blood goes back to the heart, it is at a cooler temperature. We can also vasoconstrict blood that is going to your digestive system. So for example, when you're in fight or flight mode, and you need to act quickly, blood gets actually shunted away from your stomach and your small intestine, and then towards the muscles, which would allow you to fight or flee if necessary. So this constriction and the dilation just is a really important mechanism for shunting blood to different parts of the body. Okay. We also have veins, and by definition, the veins carry the blood back to the heart. And it is at a lower blood pressure. Sometimes you can't get the blood to come out of the legs, and the blood will start to pool in the feet. And so one of the mechanisms that aids in the movement of blood up against gravity is the fact that veins have valves that prevent backflow of blood. So the veins start to move the blood up, and then if it flows back down, it's going to hit a valve, and that valve is going to close, and then maybe the vein will help to move it back up. Also, the thing with veins is that they are associated with skeletal muscle. Right? So if I'm going to walk around, I'm actually going to help to pump the blood out of my feet and back to my heart. So that's why it's actually kind of dangerous to be in a position where you have to be on your feet and standing in one place. So what can sometimes happen is that those blood vessels, the veins, become damaged, and you can get what is referred to as varicose veins, right? So varicose veins are damaged And varicose veins can be due to genetics, but it can also be due to your activity level. So if you have to stand, like if you're a cashier and you have to stand in one spot for long periods of time, you're going to be more likely to get varicose veins. So these are damaged veins. Sometimes the blood will pool in those veins and you'll get what is called thrombosis. So this is the formation of a clot in an unbroken blood vessel. So if that clot breaks free, it could go anywhere in the body. It could go to the tiny little capillaries in your brain and cause a stroke. It could go to your coronary artery and cause a heart attack. It could also go to your lungs. And so if that formation, if that clot leaves the site, so if it breaks free from the site of where it's formed, then you get an embolism. So this is a clot that is moving in the blood vessels. So for example, you could get a cerebral embolism, and this could lead to a stroke. So cerebral, that's the part of the brain where the stroke occurs. And generally, it affects the opposite side of the body. So if I get a stroke in like my right side of my brain, it's going to affect the left side because most of the neurotransmissions cross over from one side to the other as they travel to the brain. So there's a couple of things that people sometimes do to prevent thrombosis, and that is to try to increase your circulation. And so you could, for example, move, right? You could also wear compression stockings. So sometimes you see older people and they're like, oh, I have to wear my compression stockings, right? And what that does is that mimics the contraction of the muscles in the legs. And they actually have stockings that have a particular pound per inch of compression, right? And that helps to move it up. And then if you have been in the hospital recently, like, I don't know, they started doing this like maybe, I don't know how long ago they started doing this, but when I was in the hospital for a surgery, they'll put your legs in these compression machines. And so what you're doing is you're laying on your back, but every once in a while, the machine will fill up and it'll go, yeah, and you get this compression on your legs, right? And then you're like, and it'll go, shh. So you have to sleep all night long with this machine compressing and relaxing the veins in your legs, right? And what they're trying to do is they're trying to keep the blood circulating so that you do not develop a thrombus in your leg. And so the other thing about moving is that sometimes it can be really important if you're traveling. People have been known to die if they spend too long in the car without getting up and getting out and walking around, right? They have a stroke because they get what is called deep vein thrombosis, where you get a clot forming and then it breaks free and then it goes to the heart or it goes to their brain and then you end up dying from it. And so you have to realize that as you get older, you have to pay attention to that. And it's really annoying to have all those older people walking up and down the airplane aisles, but it's probably that their doctor told them to do that, right? Told them that you have to get up every 40 minutes and walk around or you're gonna get a blood clot and possibly die from it. Okay, so the veins have a thinner, smooth muscle layer. And they really do not shunt blood, right? Their goal is to just get the blood back to the heart so it can be pumped out to the lungs and pick up oxygen and get rid of CO2. Okay, so when we talk about exchange between the circulatory system and the lungs and the circulatory system and the body. This is just a diagram from your book. So the artery has a thicker layer of smooth muscle than the vein, and then the vein here, it's just showing that it has valves. So if the blood flows up and then it comes back down, the valve is going to be able to catch it. Okay. So we're going to talk about capillaries. And these are small diameter vessels where exchange occurs. So when we look at capillaries, coming into a capillary, we have a very small artery, which is called an arteriole. So we say that this end is the arteriole end, and this end is the venule end. And I didn't forget the I in venule. For some reason, they take that I out. So arteriole is just this is the way that the blood flows. So the blood is going to be flowing in this direction through the capillaries. So the fluid outside of the capillary is called the interstitial fluid. So what that means is between the tissues. So stitial is a word for tissue and inter is between. So this is the fluid that surrounds all of your cells, right? This is the fluid that's found in the tissues. And so we have an exchange between what is in the capillary and the interstitial fluid. So blood that comes in through the arterial end has a high hydrostatic pressure. So I'm going to put hydrostatic pressure is high here. So this is like you have a hose and you put your thumb over the end of it and it creates a pressure flow, right? So you just essentially took the diameter of your hose down to half or even more by putting your thumb over the opening. So that pressure that is exerted when you go from a bigger vessel to a smaller vessel is what is called the hydrostatic pressure. So it is going to force substances out of the capillary. So oxygen is going to move out, water is going to move out, and nutrients are going to move out. And this is all at the arterial end. However, the capillaries are so small that they're creating a lot of resistance to flow. So the fluid that's moving through the capillaries is going to slow down. Also, red blood cells do not leave the capillaries. So red blood cells should stay inside the capillaries. White blood cells will squeeze out if they detect there are microbes present in the interstitial fluid. Okay. So at this end, we have what is called a high osmotic pressure. And this is due to the solute concentration inside the capillary. And if you remember what I was talking about blood, there was a particular protein that is found in the blood that helps maintain this osmotic pressure because it does not leave the capillaries. It's always in the capillaries. It's the most abundant protein you have in your blood. And it is also found in the whites of eggs. Does anybody remember what that protein was called? Albumin. Okay. So we have albumin. Excellent. Okay. So what this does is this draws water, CO2, and urea, which is a nitrogenous waste. That's a waste product. We're going to talk about that not today, but on Wednesday, back into the capillary. Okay. So I could draw it going the other way. Maybe I'll use a different color. So going the other way, water is going to get picked back up. That's important. If water does not get picked up back up, you get swelling. And you've probably seen people that where their leg gets all swollen up, right? And it's not easy to move. CO2 and urea go back into the capillaries. Okay, so that's what we call capillary exchange. And you'll notice that the capillaries generally aren't just a single vessel, but they actually occur in capillary beds. So this just shows the arterial, right? And then this branching of the capillary bed. So like your skin has capillary beds in it. Okay? Even your brain has capillaries that are bringing in oxygen and nutrients to the nervous tissue. Okay, so that's the difference between hydrostatic pressure and osmotic pressure. It just sucks things back in. Okay. So what happens if things do not get picked up? Oh, I thought I had a picture of that. I'm going to write it down because we have talked about it. I don't have a picture of it. I'll write it in green. So the lymphatic system. We talked about the lymphatic system when we were talking about elephantiasis and the nematode infection that you can get where the adults reside in the lymphatic system. So the lymphatic system functions to not only absorb lipids in the digestive tract, but it picks up excess fluid lost by the capillaries. And it's always in green. So our capillaries have lymphatic vessels surrounding them. If it doesn't function to pick it up, then you get tissue swelling, which is called edema. This is tissue swelling. And then that extra fluid travels through lymph nodes up to the neck region where it's put back into circulation. Okay, but the lymphatic system is important in eliminating tissue swelling or edema. So sometimes they talk about massage therapists are like, you can have a lymphatic massage, right? And so what they're trying to do is they're trying to get the fluid to move in the lymphatic system and be taken back up. So you can sometimes get swelling down by massaging the tissue and getting the lymphatic system to move a little bit more. Okay. Do I want to talk about this? No, I don't. Talked about capillary exchange. Oh, let's see if it's on here. Okay, so this is the diagram. So this is my capillary bed. These are my lymphatic tissues, right? And they're taking the extra fluid back up from that which is lost at the capillaries. Okay, so the last thing we'll talk about is atherosclerosis. And so this is where we get blocked arteries, right? So we get what is called plaque buildup. In the lining of the arteries. So it's different than arteriosclerosis, which I'm not going to write that up, but that's hardening of the arteries. So the plaque buildup is atherosclerosis. And what this does is this decreases the diameter of the blood vessel. Right? So it increases the pressure. So it can actually lead to a cerebral accident, like for example in the brain, where the blood vessel will rupture. So it can lead to a rupturing of the blood vessel. So this can lead to, if it's in the brain, it could lead to stroke, right? It could also lead to a heart attack if it's in the coronary arteries, right? It could also be in the lungs, so it can damage the lungs. So for the longest time, they actually thought that atherosclerosis was due to dietary cholesterol. But however, they have actually found that dietary cholesterol has very little effect on the level of cholesterol in the blood. So I think I mentioned this before, that you can now eat eggs and you don't have to avoid, only have the whites. You can have the yolk, right? So you can eat eggs every day if you want to. But it has to do with the lipoproteins that transport it. So remember that we have low density lipoproteins. So these are called LDL, and then we have high density lipoproteins and HDL. So those lipoproteins are proteins that transport cholesterol. So there is really no difference between bad and good cholesterol. It's the difference between the bad and good lipoproteins. So cholesterol is transported between the liver and the tissues, and it can go in two directions. Okay, so if it is taken out of storage from the liver and transported to the tissues, that is bad. So that's the LDL. So this is bad, right? The bad cholesterol, it's good bad, okay? And then HDL is good, okay? So I'll put diet affects the different levels, and I'm going to put like a little cross between it because they don't think it has to do with diet so much anymore. Dietary cholesterol, right? So I'll put diet with cholesterol. But we know that cigarette smoking, right? Tobacco, we'll just put smoking, right? That increases LDL. But things like exercise decreases LDL. So there are many lifestyle changes that you can make that will affect the good and the bad, quote unquote, cholesterol levels in your body. This is also a leading cause of like the heart attack, cardiovascular accidents. So the way that this looks is something like this. This is my normal artery. The plaque, interestingly enough, is not in the blood vessel itself, but it's actually under the epithelial tissue. So it's in the lining of the blood vessel. If it was in the blood vessel itself, that is really bad because that can lead to blood clotting. Sometimes these clots will break free, if not the, the plaques will break free. And if they do this, this is like a massive heart attack. So if it breaks free and then blood clotting forms and the blood cannot flow, then that would be like in the coronary artery, and that's where people die from the massive heart attacks. Yeah.
So how does exercise like shrink those?
I don't know. They just know that people that exercise, it changes their levels of cholesterol. So if I exercise, maybe I get that cholesterol removed from the tissues and it gets put back into my liver. Yeah. Yeah. But too much fat in the liver is also a really bad thing. You can have alcoholism can cause fatty liver disease, and so can viral infections. Yeah. So having too much fat in your liver is also bad.
So cholesterol is fat?
Yes, cholesterol is a lipid. Yeah, but there's no good or bad lipids. We need cholesterol, but this is cholesterol buildup, right? That's plaque buildup. But it's just because the LDL transported it there rather than storing it in the liver. Yeah.
So the low density has more ability to build up rather than the high density.
Yes. And so in my family, it's genetic. So like I have high bad cholesterol, but I also have high bad good cholesterol, right? And so you can take drugs that will lower your LDL, but those also have really bad side effects. At least in my family, they do, yeah.
And so they say diet can lower your cholesterol.
Yes, so if you eat good food, like lots of fibers and vegetables, that can, but they don't believe that dietary cholesterol will change. So like you can eat cholesterol, so specifically eggs. They kind of decided that taking eggs off the plate for people was a bad idea. That eggs actually are good food, good nutrients, good enough that it doesn't affect. Yep. You can Google that too. So dietary cholesterol and heart disease, and there's all this research behind it. Okay, so we'll stop there for today, and we're going to start on the urinary